Good morning, everybody. Welcome to the first series of our spring series of 3 webinars hosted by the New Jersey Statewide Network for Cultural Competence. Before I begin, I just wanted to say a few words about the NJSNCC. The New Jersey Statewide Network for Cultural Competence is a collaboration of private and nonprofit agencies who have partnered to develop a broad-based network to advance culturally and linguistically appropriate service delivery and practices in New Jersey. We were established in 2002, and we currently have more than 130 public, nonprofit, state, community, and private sector agencies engaged in or promoting culturally and linguistically competent service delivery, education, policies, and practices. Today's webinar is Becoming a Culturally Competent Medical Home, a model for providing patient and family-centered care to children and youth with special health care needs. My name is Zenaida Steinhauer, and I'm a member of the leadership team of the NJSNCC. I also work full-time for the New Jersey Department of Health, and I will be the moderator for this webinar. Before we start, I would like to address a few housekeeping items. Because of the number of participants, we will be muting your phone lines throughout the call. This webinar will be recorded and archived on the NJSNCC website. Using the webinar technology, you can submit questions at any point during the presentation via the chat or question box on your webinar console. You can send questions at any time during the presentation. There will be a 5-minute break mid-presentation, so Helen can entertain a few questions. So if you have any questions, you can type it in the chat box, which is on the bottom of your console. I will be compiling other questions which will be addressed at the end of the session. We may not be able to pose every question to the presenter and may combine some questions if they are similar. Finally, a short survey will pop up on your screen immediately following the webinar. Your feedback is important to us, and we appreciate you taking the time to fill it out. Now, I'm honored to introduce our speaker for today, Helen Dow. Helen is the President and CEO of Dow Management Consulting Services in Jersey City. Helen is a healthcare consultant specializing in quality improvement projects and healthcare strategic planning. She has comprehensive knowledge and expertise in facilitating the NCQA CCMH application process for multiple sites with a record of achieving Level 3 recognition. The meaning for NCQA or PCMH is National Committee for Quality Assurance, and PCMH is a patient-centered medical home. Helen has expertise in developing, implementing, and monitoring QI programs and activities as it relates to clinical outcomes. She is skillful in training staff on new and or revised clinical policies and QI processes and ensures that program operations adhere to standards. Helen ensures that clinical staff understand their performance on evidence-based clinical measures and provide advisement on appropriate clinical interventions to facilitate improvement. Helen holds a master's degree in healthcare administration and a bachelor's in psychology, both from the New Jersey City University in Jersey City. Her previous presentations include care coordination training for primary care providers within the PCMH context, cultural competency for educators, cultural diversity and public health, cultural brokering, how to work with limited English proficiency patients, and many more. Now I'm honored to hand over this presentation to Helen. Helen?
Yes, thank you, Zenaida. Good morning, everyone, and thank you for attending today's webinar. As Zenaida mentioned, today's topic is about becoming a culturally competent medical home, a model for patient and family-centered taking care of children and youth with special health care needs. The purpose of today's program is to continue creating awareness around the global individual needs of children and adolescents with special health care needs, and how a culturally competent medical home can have more impact and positive results in care for children and youth with special health care needs and their families as well. We will start this program by going through the motion of creating a patient family center medical home. Then we will incorporate some important characteristics of a culturally competent medical home and look at the process of identifying, linking, and collaborating with providers sharing the same goal of building a culturally competent medical home. Before I do want to address, the main program goals for today's presentation, we do hope that by the end of today's program you will gain new knowledge, new skills, and some new ideas in how to collaborate with your organizations or other practice teams to build a culturally competent medical home for children and youth with special health care needs. We will define and identify methods for building a culturally competent medical home. We will review strategies to connect children and youth with special health care needs with a culturally competent medical home provider, which is a key, as you probably all know that. We will discuss approaches that will be used to engage the practice team and integrate care coordinators within the clinical practice settings. I know that many organizations and practices use interchanging titles for the care navigators, care managers, or case managers, or patient care navigators. For today's presentation, we're going to use the care navigators, interchangeable with the care coordinators. We'll describe incentives. What are the incentives that will help engage medical providers to buy into the medical home concept and help them understand how important it is? And lastly, we want to customize a medical home model that fits your community needs and effective methods to educate families about the medical home. This last goal is important because we want to make sure that as we are building a culturally competent patient family center medical home, we take in consideration the specific needs of your families as well of your practice. So one model can be modified based on the individuals and the practice needs. So who are children with the special health care needs? Let's review who they are, and which is defined by the Maternal Child Health Bureau, are those who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition, and who also require health and related services of a type or amount beyond that required by children generally. As we all know, children with special health care needs will have more medical, behavioral health, and psychosocial needs than other children from the general population. Here are some of the disabilities and chronic conditions affecting children with special health care needs. Some of those disabilities are autism, cerebral palsy, developmental delays, ADHD, depression, mental health, related issues. In the chronic illnesses, we have children being affected by asthma, sickle cell anemia, cystic fibrosis, and epilepsy of seizure disorders. In many cases that we've probably seen and know that children with special health care needs might be affected by disability and a chronic condition. So that puts tremendous need for children youth with special health care needs to seek multiple health care providers and so specialists, and also how that impacts the families or the caregivers that look after them. Based on our Center for Disease Control and Prevention survey, it was identified that children with special health care needs have 80% need for prescription medications, 52% need of specialty medical care, vision care 33%, mental health care 25%. And I do want to make a notation here that in regards to the mental health services, we're starting to notice a more increase of pediatric mental health services for children with special health care needs. And the utilization of medical equipment by 11%, as well as specialized therapists by 33%. So this survey was conducted between 2005 and 2006. The medical home model was developed by the American Academy of Pediatrics back in the 1960s, and if I remember correctly, my readings is that it really started as a complete different model. In the 1960s, started as medical home being the medical record room or the central medical record for, all the healthcare information for children with special healthcare needs. As we can see how the model has evolved throughout the decades to where we are right now. It has become more defined in recent decades. Medical home is defined by the American Academy of Pediatrics as a source of ongoing, routine health care in the community where providers and families work as partners to meet the needs of children, youth, and families. What this means is that the medical home assists in early identification of a special health care needs, provides ongoing primary care, and coordinates with a broad range of other specialty, ancillary, and community-based and related services. So it's a really comprehensive, model where the children's and youth with special health care needs are addressed not only from the medical perspective, but also as preventive care services and continuity of care, and connecting and linking to community-based services. And we will talk in more details as we progress in the presentation. Another definition that is very important to know, and I mentioned at the very beginning, is that the role of the individual as a care coordinator, patient navigator. The Maternal Child Health Bureau defines care coordination as services that promote the effective and efficient organization and utilization of resources to assure access to necessary comprehensive services for children and youth with special health care needs, including the families as well. Care coordination, it first started as having someone, being the main person to connect children and family to medical services and non-medical services. It was sort of the solo, practitioner of this individual, practice of this individual. That has also changed. I think that we all know that in order to provide comprehensive care coordination, it needs to take a team approach. It's not a solo effort anymore, and we will talk in more details about the role of care coordinators in the patient-centered medical home. So when it comes to medical home characteristics, there's a lot of information out there in regards to, how do we go about accessing services for children and youth with a special health care needs? How do we make sure that all the care is well coordinated and that all providers, healthcare providers, are communicating with each other. For instance, the physician and the subspecialist, how do they maintain ongoing communication about the children's healthcare needs? So let's talk about that in regards to what it means medical home being accessible. Care providers is having access to care providers in the community, meaning that the children and the families can access, immediate services from a healthcare provider in the community, that they don't have to travel long distances in order to get to one location from their home to the care provider. And some of us might say, well, here in the inner city or metropolitan area, we don't have that issue. We do need to keep in mind that some of our children and youth with special health care needs also have physical disabilities. So when it comes to traveling long distances or long period of time from home to the provider, that also puts a burden on them, and it can be extremely uncomfortable for them. So having, that immediate access, it is crucial. Also, the medical home providers accept all types of insurance, including Medicaid. We still see some medical home providers or practices that do not accept certain health insurance, and that really prevents these children accessing the services that they need at that moment. So it is crucial. In order to truly be accessible, we need to be able to, for practices to accept all types of insurance. accessible to public transportation. And also having same-day appointment. I know that when when the same-day appointment model came, it was a lot of the practices weren't sure how to go about this, and we still have many providers struggling trying to figure out how can we build in same-day appointments within our practice. And I guess one of the concerns they had was, well, if I open up more slots for same-day appointments, will I lose the opportunity in actually scheduling someone to come in for the appointment? What if they don't show up? So it has been proven that it was more of a, a concern and being worried about this becoming a problem. Now, medical homes that are implementing same-day appointments are actually have increased the number of patients that they can see. They also decreased the no-show rate. So it really shows, it continues to show that it was a good decision. Medical home, another characteristic is the patient-centered care. How important it is to, build a mutual responsibility between the providers, the healthcare providers, the office staff, the patient, and the family. How all decisions, need to be made, involve the family, the child, and the youth as well. And develop that trust between parties is very important. And building the trust also helps for families to, share decision making with the healthcare providers. Well, the healthcare providers will feel that, let me hear what the parents need to say, because we need to remember that parents are the experts in the child's care and who they are, and keeping in mind that parents have a tremendous amount of information to bring into the care of this child is extremely important. It's based on the relationship building. It's based on establishing trust between the families, the patient, and the healthcare providers. So it is extremely important to really be patient and family-centered. We need to look at all these different, components that need to take place. And also the, the medical home is defined as being comprehensive. What does it mean being a comprehensive medical home? Some of the aspects that we can look at is providing preventive care services to children and youth with special health care needs. So it's not just addressing the chronic condition or the disability that the child has, but also being proactive. What are the type of immunizations that they need to have at this age, by this time? Are they getting the flu shot on time? Are they getting healthcare screenings done on time on an annual basis? Are they receiving also, the parents and the youth receiving information about different health issues that they might, be facing at the moment? So it's really coordinating and looking at the proactive, from the proactive point of view to the chronic care management that the child or the youth might need, and to looking into also in the future preparing the children, the family, and learning healthy living skills and equipping them with the right knowledge and skills in order to make healthy decisions about their lives as well. The coordinator care that is provided in the medical home, it's something that really starts pulling all these different characteristics that we have been talking about so far when it comes to a medical home model. Coordinator care is developing the primary care physician, the child and the family, developing a plan of care. Setting up goals based on the child's needs or the youth needs, and including the family as well. A plan of care is something where it's not dictated anymore by the physicians. It's the patient and the families are the ones that are making those decisions, because that is the guide. That is what will determine what kind of services, at what time, at what point those services will be needed or delivered. And tracking all referrals when it comes to physician referral to subspecialty care, labs, imaging, community resources referrals as well. Where are the non-medical referrals, being done, and how are they being tracked? Here, the Care Navigator plays a big role, because this is, for most part, the individual that works side by side with the families and the providers in making sure that all these services that are being prescribed by the plan of care are being followed through and are being accomplished. It is compassionate. We want to make sure that the healthcare providers and the office staff truly show concern for the well-being of the child, that we always look after the best interest of the child and the family. And lastly, that is culturally effective. I always have a problem. Why did we put cultural effective lastly, number 7? But I was trying to understand, cultural effectiveness really plays a role in all the different 7 characteristics that we are addressing here. Being culturally effective medical home, which we'll be talking more details after 5-minute breaks in how to build a culturally competent medical home. But being culturally effective, means understanding and taking into consideration the cultural backgrounds, beliefs, and customs of the family, and how that will be incorporated into a plan of care and the plan of care of this child in the family. That really is going to drive how healthcare providers communicate and interact with the child and the family. What kind of cultural background and belief do they need to keep in mind as they're making suggestions about treatment, or they're making recommendations about certain treatments in medication as well. And also understanding if cultural beliefs play a role in medication adherence, or perhaps getting some of the preventive care services, such as immunization for the child. So these are key things to keep in mind, because it really can put us in a situation making unfair conclusions about families not adhering to the treatment. Some other components with similar characteristics, including cultural competency, is the partnership between professionals and families of children with special health care needs, access to cultural competent family-centered medical home, which coordinates care to pediatric subspecialties, access to adequate health insurance finances, which is sort of what we just discussed previously, early and continuous screening for developmental disabilities or chronic conditions. This is, very important to keep parents informed and educated about this type of screening. So they don't fear, they're not concerned. It is normal for them, to be a little apprehensive about this, because, it can be very, intimidating or nerve-wracking for them. Organized community service for easy to use by families. As based on the community-based system needs to be, readily accessible by these families, whether they need, parents need a support group, a parent support group where they can come in and meet other parents that have children or youth with healthcare needs, and they can, sort of share their experience and see that, they're not alone in this journey, and that they can find comfort with other parents, and also in a lot of cases also they are, support groups for youth with special healthcare needs. At least I know for children with epilepsy, seizure disorders, there are youth groups where they can come together, socialize, and share things that they have a mutual interest in. and also assisting with transition to adult health care. One of the things that, is not much talk about is about children with the special, and youth, primarily youth with the special health care needs when it comes to the point of education transition and employment transition. And that's something that it should be part of the plan of care. It should be included, and sometimes parents don't know that they can ask for this, but it's important that we are not looking just at the health care services for the child, but we also look at the education. If they're going to be transitioning out of high school, are they going to college? Are some of them going to a day program? So what is the transition in place for them? The same thing, with employment, if they are moving from one job to the other, how is that being arranged for them? And these are things that should be discussed with the medical home provider, because at one point it will affect at the emotional level for this youth with the special health care needs. So we do need to have, with all that have been said, what are the things that we need to keep in mind and have better understanding and the positive impact of a patient-centered medical home. Why do we pay so much focus and so much attention and resources, as we can all see, not at the national level, at the federal level, in building patient-centered medical home for patients and families? Because providing, having a medical home is, that is comprehensive. It helps, have greater access to community services, improves the skills for self-advocacy. And this is very important because as, our organizations, patient advocates work with families that have children youth with special health care needs. One thing that is very important is that we need to work with parents to develop the develop advocacy skills. A lot of our parents, might come to us, or we might start working with them. They're a little shy, a little intimidated, and they are overwhelmed as well with, with either so much information or the lack of information. So I think that, one of the things that is crucial is that the medical home providers building a structure where parents, children, and youth can become self-advocates as well, where they can learn about the condition, so they empower themselves with the knowledge, and they're able to communicate their needs that they have in order, in what their goals are, what is that they want to get, in order to live a, a healthy and fulfilled life. The opportunity to connect with other families, it is important because as the medical home model, the medical home providers are building these internal structures to make sure that the families have, and children youth with special health care needs have access to service. They're building these structures where they are able to connect with other, individuals that have similar needs as well. And the knowledge of living a healthy lifestyle and making healthy choices as well. Another reason is because it really increases the capacity, to navigate the system. I think many of us have found ourselves in a situation where, we are pointed to go somewhere and to figure out how this service work or how this program work, and we feel lost and sometimes overwhelmed because, oh my goodness, if it is not something that we used to doing, it will be overwhelming. So listening for a moment, what might be like of for a parent, especially in a newly diagnosed child with a special health care needs, whether it's a disability or a chronic condition, how overwhelmed the parents might feel at that moment. And so much information and resources that is out there, but do they know how to access that? Probably not. They will learn it. They will definitely become self-efficient in regards to finding resources, but not everybody, will acquire that skill at the same pace or at the same level. The other thing to keep in mind is, linguistic barriers or cultural barriers, where, excuse me, where, individuals have, English proficiency is a problem where I do not speak English. They cannot read the English language. So that becomes a huge barrier for them and even, intimidates them more because they don't know how to go about asking questions and accessing those services. So the medical home providers have the responsibility in ensuring that the families have access to linguistic services and information. So now we're going to talk about the four main, areas of the patient-centered medical home, which, they are the four pillars. And the first pillar talks about, improved teamwork, effective communication, a lot of practices, and I even, know that in non-medical organizations, they practice the team huddles, and probably some of you might be doing that on a daily basis, and you haven't realized that you are huddling on a daily basis to talk about what the day is going to look like. So when it comes to the patient-centered medical home, team communication is the daily huddles are so essential because it really sets the tone for the rest of the day. So the way it works is, ideally we want the practice teams to do pre-visit planning. So they know that in advance all the children and youth with special health care needs that are coming to their facility, the reason of the appointment, who is coming for just a follow-up, who is coming just for a referral or perhaps, a preventive care service such as immunization or a flu shot, or who is coming, because there is more of an urgent need that the child might have and needs to, be evaluated by the physician. It really sets the tone of the practice for that day. And who are the individuals that participate in this team? We have the physician, the nurses, the care navigator is, it's a big contributor to these teams, social workers, the registrars, and your team will really, vary from practice to practice. So it's not, these are the list of individuals that I'm giving you is the way that it should be for every practice. No, because you might not have a registrar. You might be a smaller organization with a small practice where, it's just you, the nurse, and the office manager. And that's fine. That's, you can huddle and accomplish a lot. And then you have your bigger teams. So the important thing is that communication is ongoing. Teams are communicating, team members are communicating with each other and sharing information. So care coordination, as we have said before, is a huge component of a patient-centered medical home. It promotes efficiency, continuity of care, focus on helping those in the home get their needs, makes access to care easier, and creates a friendly and support environment for the children and the families. Our second pillar is interagency partnership. Interagency partnership, it's what it means is developing trust with, other healthcare providers. I connect families to resources at the local, state, and the national level. It doesn't just have to be, a partnership in your local community, but it can also be partnership with national centers or national organizations where you can have access and information for the family of children with special health care needs. It also is to develop a strategic relationships in order to build an integrated network of services. how are you developing the community partnership? What kind of community resources are you creating? And you can also, develop a community resource directory for your staff to use and for the families as well. And cut it through the red tape and expedite solutions. What it means is, is based on established trusted relationships that you have developed along the way, where you feel comfortable in picking up the phone and calling, the other office practice managers say, I really need this person, this child to be seen ASAP because it's urgent. Not to say that the other patients don't have any urgent matters, but, it really goes a long way on how you establish those working relationships. Another important one is the co-management care partnership, and that is between the physician and the subspecialty care providers, where it's a mutual agreement of what the expectation is, and this is only for the to improve the quality of services for these children, where if a physician is making a referral for a test or a subspecialist to, provide his evaluation, that is conducted in a timely manner, that the subspecialist, as a consultant, will, submit the report on time to the referring physician, so that way there is a, ongoing process in regards to having a timely evaluation for this child. The third pillar, really focuses in regards to surveillance and tracking systems, utilizing patient registries. I'm sure a lot of you might, have or are very familiar with how to develop and utilize patient registries based on their condition. For children and youth with special healthcare needs, it's very helpful to understand the acuity and complexity of the needs that these children have, because it really helps you to make informed decisions about the right care and the right services that they might need. Also, the utilization of tracking systems and the database, how you're keeping that information, not every organization or practice will have electronic systems where you can have, electronic referral tracking systems and database, but also using the traditional way, which is, nice spreadsheets that are super efficient, I believe, can also help us and help you, keep all the care coordinator and organized, where the patient navigator, plays here a big role, because he or she is the one that is assisting the physician with the referral tracking, with test referrals and procedures, and what is being done, and also what are the services that the children need at the moment or will be needing in the near future. And that goes into also organizing the clinical information. How do you maintain the patient's medical record? Again, some organization practice don't have electronic medical record, but they have their own traditional system in how to keeping patients' medical records in order. And also, that helps in meeting the requirements from regulatory institutions, such as for those that are community federally qualified health centers, from HRSA, in maintaining all the requirements, in place for the clinical information, and they're able to meet those requirements. And the fourth pillar is, it speaks of the best practices based on evidence-based guidelines. I think that I would say that for most part, all organizations, at one point we have referred back to what are the best practices, or what are the, evidence-based guidelines that we should also be incorporating, integrating into our setting. So when it comes to, identifying pediatric, quality measures for children and youth with special health care needs. What are the things that you are, incorporating, in regards to for immunizations, for children that are asthmatics? What are the evidence-based guidelines that you are following in order to provide appropriate treatment and care for children with asthma? If we are referring, children with mental disabilities, what are the evidence-based guidelines that you follow in your practice in order to, provide the appropriate treatment and care for these children, and as well referrals. Track how well the team incorporate these measures. Do you have a designated nurse or quality assurance person that will help you, track that by conducting charts review to ensure the appropriate practices are in place. And here are some of the resources for quality measures that you can refer to, once you have a moment to do that. Accessible means having access to health care. We talk about this, so we're gonna, skip that. We also talk about same-day appointments, physical access, and comfort for children with special health care needs. This summarizes the practice team development that we have been talking about. I'm not going to go into details, and all my slides will be available for you as needed. And it's really, forming your team practice. What are things that you need to think about, and how do you formalize and incorporate it in practice at your organization? Sanida, I think that if we have time, we can probably take a couple of questions. Okay, so we'll moving on. So we will, now start discussing in regards to hello.
I'm sorry. I think I muted myself. Okay. There, I'm so sorry, everybody. If you have any questions at this point, we can take a 5-minute break, so Helen can entertain a few questions. There is a chat box on the lower right-hand corner of the screen. So if you do have any questions, we will entertain them. You can just type that in the chat box, and I can present it to Helen. If not, I don't see any questions right here, right now. So Helen, I think we can just proceed and wait till the very end to address any other questions that may come up. All right.
Okay.
Thank you.
Thank you. Okay. So, next week, how to integrate the medical home principles in a culturally competent medical home model. We're really implying that, adapting the medical home principles and integrating into a culturally competent medical home, will really impact and enhance the quality of care that children and youth with special health care needs will receive. We want to make sure that it's culturally accessible, meaning that there are bilingual staff, interpretation services available to children, youth, and their families when they come for services or when they call the organization or practice. And please keep in mind that I think that these principles don't all just apply to the medical home model, but these are principles that can be adapted to be incorporate your agency organization as well. So everything, is transferable, I would say. There is linguistic comprehensive, that the information that is given to the children, youth, and families is linguistic comprehensive in the verbal or the oral form that is written in the native language in a simple context. Not too much verbiage. The less verbiage, the more visual is better. And also the body language. I think that, this is so important because something, that we have seen, happening is that when families come to an agency or a practice, it's important for staff to know that sometimes body language can speak more than 1,000 words. There's a saying like that. I might not getting it right, but it is. And if a staff was having a bad day, and the parent asks a question and the side-eye, the soft side-eye or roll of the eyes, that can definitely send a complete, wrong message to that parent and might prevent that parent from actually accessing those services there. There is culturally competent resources coordinators. That all resources that we seek for children, youth with special health care needs, and the families are culturally competent, meaning they're in the native language and that they are written in a simple context, and that is taken in consideration as well. There is patient-centered and family-centered, very important. And there is continuous holistic approach from birth to death. That's what we mean, that we are keeping track of all the services for these children and youth, and all and it goes without saying being compassionate. A culturally competent medical home understands that patients with disabilities and a chronic health condition come from many different cultural backgrounds. That there is a clear understanding that what works for one family might not work for another family in regards to communication and how to approach the situation. Also, how they interpret and understand the condition of their child. It helps patients understand the concept of, helping patients understand and the families the concept of the medical home, what it means to have a medical home provider that is culturally competent. Is having someone that they can speak to in a native language. And I understand that, it can be sort of a little unrealistic to think that, well, every provider needs to speak the patient's native language. That's not possible. But for practices to seek for those resources that are available in order for the patient to receive the information in the native language ensures that patients' cultural differences are understood, respected, and addressed according to the individual's needs. It's important not to, judge quickly and say, parents are non-compliant. So that's sort of not a good word to use. We really need to understand where those decisions are based on are based on cultural beliefs, and that's important to understand. And the patient's cultural beliefs come first before any medical fact or statistics, because, we do see a lot of healthcare professionals, saying, I wish my patients will follow through or will be adhering to these or come to the appointments. But let's try to understand. Sometimes it might be just a matter of listening to the family, or what is that is stopping them for accessing those services, and then we can make those accommodations based on those cultural beliefs and make sure that a child is getting the services that they need. And that is culturally, cultural competence diversity must be the one on top of priorities when implementing a patient-centered medical home. I have been doing a lot of trainings with healthcare providers and for care coordinations where, it always comes back to this, that we must be able to match care coordinators, at least with patients that meet some of the cultural linguistic requirements, where the families and children with special health needs can relate back to the patient navigator because they can speak the same language. Another tool that we have used and is the integration of a cultural broker into the medical home. And the cultural competent medical home also, it implements these interventions. People with that these are individuals with deep knowledge and understanding of children with special health care needs, cultural linguistic needs. This model, obviously, is adapted from the National Center for Cultural Competence. So if anyone is not familiar with the NCCC, please go to the website, ncc.org. And they have, so much valuable information in regards to cultural competency. But cultural brokering, is defined as a healthcare intervention, where professionals increase in the use of culture and health science knowledge and a skill to negotiate with the patient and the healthcare system for an effective beneficial healthcare plan. And a cultural broker is a liaison. It's a cultural guide. It's a mediator, someone that works, with the families, with the patients, and the healthcare providers, as well as an organization as a whole. And the cultural broker can also serve as a catalyst of change to assist healthcare providers and organizations in adapting policies and practices. I think that the cultural brokers, in my opinion, are underutilized because have seen the tremendous impact they can have when healthcare providers are having challenges in communicating or really understanding the family's point of view based on the cultural beliefs. Here are some of the interventions, outcomes, when using a cultural broker. Cultural issues become important consideration to address during case conferences with professional healthcare providers. Increase the communication between families and providers because you have this person as a mediator, and whatever was misunderstood is now, can be clarified by the cultural broker. Families become more comfortable. They feel that, I'm sharing information with someone that really understands my cultural background, my cultural beliefs, and I feel that they will be able to, relate back to the providers as it was me speaking to them because they truly understand me. Improves providers' openness to receiving information about families. So it's, it's a two-way street where the patient, it's a win-win situation, I should say. Patient is getting the information they need. The family is very comfortable. Now the provider is able to, to prescribe the treatment and to see that that the child is getting the services that they need. And establish partnership between providers and families to create shared solutions to each of children with the health care needs. So it's a very valuable, model that should be implemented. When it comes to high-level performing practice, communicates across cultural, these are some of the things that, will be, useful in regards to achieving high-level performance practice once you have incorporated cultural linguistic appropriate services into your organizational practice. These are some of the challenges that we, have encountered, and we have, the medical homes providers have encountered, and that also needs to be addressed. The inability to communicate with the management, patients not feeling that they're being listened or they can, speak with the management to share their concerns or maybe the unsatisfaction of the services. The inability of organizations to assess the patient's cultural and linguistic needs because they don't have the resources or the individuals with the skills to perform these assessments. So assessments about, the patients and the population cultural linguistic needs are crucial. Also, failure to get children youth with special care needs access treatment and get services because perhaps the consent forms are not written in the native language, so the parents might be a little hesitant in signing those forms because I'm like, I don't understand what they're saying, so why would I sign something that I don't know? It prevents the child from accessing treatment of those services. Enable organizations to provide services in a manner that is culturally effective, not meeting the cultural linguistic demands of their patients and families. These are some of the additional risks of quality of services related to potential barriers as well. And competent dealing with the diverse population is crucial. The lack of it has a specialty adverse consequences. So as we can see, failure to truly incorporate cultural competence as part of the medical home model, it can be detrimental because, yes, we can have the structure and we meet all the guidelines and regulations, but if the families or children and youth with special health care needs are not able to understand what is given to them, what being offered to them, it serves no point because no one will be accessing those services efficiently and effectively. These are some of the related financial costs or savings. This was a very, started between 2011-13. It was one practice only, and they show that, between that time of the that period of the survey, it was identified a decrease when it came to children with serious illnesses being hospitalized. And also the hospital and clinic costs went from 16,523 from 26,781 to 16,583 per child per year. As you can see that, obviously this is one practice. Their recommendation is to continue doing more studies in regards to, have a more significant, outcomes in regards to the impact that the patient-centered medical home is having nationwide for children and youth with special health care needs. These are some things for us to think about, into the future. Do we feel that healthcare providers know and understand the medical home? Having a culturally competent medical home improves the quality of care for children and youth with special health care needs and decreases the cost for medical home providers and health insurance providers. And do we think that cultural brokers are being used enough as part of the medical home model? And these are the next steps, that, we are recommending, in regards to conducting practice self-assessment to find where you are in regards to the medical home model integration. But also, as you are building these steps and looking at these steps, keep in mind the integration cultural competency as part of the medical home model. Develop policies and procedures for providing interpretation of bilingual services to meet the language needs of your population. And conduct periodic assessments of racial and ethnic diversity and the population language needs. Remember that, we are, communities tend to change, demographically change. For one day it might be, primarily serving one language, and then little by little we start noticing that we're getting new patients, coming in that speak a language that we don't speak. So that should be, a red flag right there. What's happening in our community? What's changing in regards to the demographic changes? I will stop at this moment.
Helen, we have 2 minutes to wrap up. Okay, thank you. Go ahead.
Yes, so I think that, our goal of today's program is to, make sure to give you some, tools, some ideas, some tips in how to, if you're already, incorporating or integrate the patient-centered medical home model, you practice, or you're working with someone that you always keep in mind when it comes to children and youth with special health care needs and the families. They are a great, sense of cultural linguistic needs that they have. So making that part of your medical home model would truly, bring you to a high performance level. So I do want to thank you for your time in participating in today's program.
Thank you very much, Helen. Helen, we do have some questions from the audience. One question is there training or preparation for one to be a cultural broker? If not, could one be developed, and how would language interpretation fit in with culture brokering?
Yes, thank you, Sanida. The first question, I do, have adopted a cultural brokering training from the National Center of Cultural Competency, and I have worked with them very closely in modifying that curriculum. So I myself provide that training. It's a 2 full-day training, but also the National Center for Cultural Competency have a vast of information and resources when it comes to how do you adapt, some of the best practices for a cultural broker. A cultural broker can be anyone, can be someone that you have at your practice, could be definitely key having someone from the community. But I will be happy to, if you would like to follow up with me offline in regards to that training, I'll be happy to give you more information about that.
Okay.
In regards to interpretation services or linguistic and the cultural broker, I think it's important to make the difference between the, someone that is an interpreter and someone that is a cultural broker. Obviously, those services will overlap. A cultural broker, will also serve as an interpret, but an interpret might not have the deep understanding and knowledge of the cultural, background, practices and beliefs of that community. So there definitely can be, an imbalance there. But someone that is an interpreter and would like to become a cultural broker can be trained to do that as well.
Thank you. And Helen, can you please show the last few slides? And while you're doing that, how is this service funded?
Which service?
I guess it has to do with cultural brokering. Is that what? Yes.
Oh, yes. So in regards to the training for the cultural broker, if the question relates to that, that is something that is done, from my consulting practice. We do it privately, and there is a fee for that. But we'll usually work with the organizations. We try to work with the budget, if that's the question. But there is a lot of free resources online as well around cultural brokering, and how to implement it. So, you have the two options as well.
Okay. At this point, I would like to thank Helen for that very informative and impactful session, which explains the culturally competent medical home model, the role of care navigators in implementing the model, and how this model produces positive results for children and their families. For those of you who have additional questions, please send the questions to Helen. Helen, it's her email address is that address on the very bottom of the screen, www.dowconsultingservices.com. So on behalf of the New Jersey Statewide Network for Cultural Competence, I would like to thank each and every one of you for attending this webinar. It will be archived and made available for you on the website for the NJSNCC. We have another webinar scheduled for April 16, so please tune in to that as well. It focuses on language and interpreting. And please don't forget to complete the survey, which will appear on your screen once we end the webinar. So thank you so much. We have come to the very end of the webinar, and we hope to see you again at the next webinar in April. Thank you.